So hope everyone's enjoyed the morning session so far. Had a little lunch, gambled a little bit. As you probably saw from the presentation this morning, I'm Michael from my mugshot. I'm from Nashville. I work at Vanderbilt University there with our acute care and emergency nurse practitioner program. Work as an EDNP, acute care and family background. And for those of you that aren't aware, there is now a new ENP certification for us NPs that work in emergency medicine. And that's available through the ANCC. If you haven't looked at that, please check that out. We actually now have a board certification for us to actually show our specialty care for that, and I'd be glad to answer any questions during breaks about those as well, but it's all available on the ANCC website. It's not what all of us wanted for, but at least it's a start. I've been involved with their expert panel projects on that, and at least we're moving forward with that. So our next topic, talk about a little bit about head trauma and the evaluation and management of those patients there in the ED. And we'll talk a little bit about the major patients, but mainly more about the minor patients, because the minor ones are the ones that we really have to focus most time on. As we'll see in a few moments, major trauma is pretty easy for the head. It's get them to neurosurgery, get them to trauma, wherever they need to go. But we do see a lot of head injuries there in the ED, and we know that unfortunately we do live in a very litigious society. So what is the best way to manage and assess these patients? What is evidence-based? And we're going to look at some of those studies and talk about the use of CT scan and when it's appropriate, when we can actually just go with physical exam and still treat the patients the best, and of course also protect ourselves. We think about the anatomy of the brain, the different structures there we focus on with our assessment findings. What do we see? If the patient has any neurodeficits, what are they distributing to us? What are they telling us in their history? What are the parents, the family, whomever that was there telling us about what symptoms they've had to kind of get an idea of what type of injury they may have sustained or what area of the brain actually is involved in. Especially when we talk about trauma in general, majority, over 50% of all trauma patients are going to have some type of head injury. So something we have to keep in our list of differentials when we're evaluating those. Do they have the risk based on the mechanism? And do we see anything physical exam-wise that makes us very concerned about those? A lot of those do involve the younger Caucasian male group that usually is preceded by, hey, y'all watch this, hold my beer type stuff. Or at least that's what I'm used to seeing in the South, because it all involves some type of alcohol. But major stuff is pretty simple. But the minor stuff is what we're going to focus the most on. Scalp lacs, as most of us have seen, they can bleed a lot. Especially we've got the patient who's on anticoagulants, antiplatelets, the alcoholic patients. But even with pediatric patients, we have to think that they can lose a large amount of their blood volume very quickly with just what we think is a very minor scalp type lac. So how can we manage that? Direct pressure we know is very good and very effective. Rainy clamps are something that some of us may use to get those skin bleeders. Stapling, the injection with Lepi and lidocaine may work as well, but a lot of these patients, especially with their own son that's going to thin the blood, definitely going to need some pretty significant aggressive intervention to stop that. And even with their pediatrics, they can lose a lot of volume very quickly and lead to some hypovolemia very quickly. So we need to be aggressive with those patients. It's amazing working with transport and also working in the ED when we move people over from EMS stretcher, the amount of blood that we see there in the crevice of the stretcher, and a lot of that usually comes from the head, and they bleed out a lot. So just keep that in mind that we really want to focus on those. And especially we've got the hypotensive trauma patient with a closed head injury, we need to think about something else. That's probably going to be chest, abdominal injury, long bone trauma, not just the head. Typically, we think about head trauma itself, we usually are going to see the opposite. With isolated head, we're going to expect to see the hypertension, especially when we talk about Cushing's triad and the brain trying to compensate for that drop in perfusion. The Glasgow Coma Scale, just a very quick but gross way to assess neurological status. It does allow us to quantify their neuroassessment, especially to see if they're changing, to go if they were originally a 14, now they're a 13 or a 12, but it does give us a way to serial that if we're doing serial assessments or evaluating those patients. But it's very gross. I mean, you get 3 for just being there. I don't know too many other exams that you get credit for just being present, whether you actually do follow the commands or not. But it is a gross way, but it does give us a way to quantify that assessment and see how they do moving throughout the assessment, especially if we're doing observational status. We're trying to rule out other things without going to radiographs, especially in pediatrics. With skull fractures, depending on the type of injury we're looking for, depending on the management, some of these can be very minor, especially when we think about linear fractures. We may not do anything with those and send those patients home. If I am worried about some type of a stellate fracture, really think about abuse. Do they have some type of direct blunt trauma to that area? We have to do good history in trying to figure out what all happened with those patients. Those with obviously open injuries, those with depressed skull fractures, those are going to require services outside of our capabilities, but get them their necessary care as quickly as possible. We need to focus on antibiotics, even though they may not help limit the risk of meningitis. the need for seizure prophylaxis, and of course, if we need to treat ICP, whether we're using mannitol or even hypertonic saline can sometimes be used for those as well. If we're worried about those basilar skull fractures, do we see cranial nerve involvement? Do I see things that make me really concerned about that specific type of injury, which we'll look at in just a few moments? But radiographs can help us a good bit. Sometimes plain films are used, but they're not as good as using CT or even going up to MR in some scenarios. But now they're great technology. I mean, we can get a great 3D image, as you see here, to really get a good idea of what's going on with all the different facial structures, but also the bony structures involved. But definitely, these are patients going to require a good bit of imaging to get a good idea of what's there or what their risk is. Especially if I'm worried about temporal bone fractures, always keep in mind that that patient does have a high risk for an epidural bleed. Most of our epidurals that we do see are associated with a temporal bone fractures there at the middle meningeal artery. And as you can see here in the film, and we'll look at several of those differentiating epidurals versus subdurals, that epidural has a very classic convex look. It has that contact lens look, which makes it pretty easy to differentiate from a true subdural based on those radiographs. With those basilar skulls that we're worried about, do they have the periorbital ecchymosis? Do they have the mastoid process bruising? And those are good things we can look for. Which one tends to show up first? Which we see most there in the ED on initial presentation? It's that periorbital. That usually occurs pretty quickly. We see that a lot with patients. But that mastoid process bruising, the battle sign, that takes several hours. And some references say up to 24 hours for it to be present. So that may play a role in our history, especially for pediatrics. If they come in and they've already got both the battles and the raccoon eyes, have to worry about abuse, because you don't follow bed and come in an hour later and already have mastoid process bruising. It takes a little bit longer than that. So just keep that in that list of differentials if I'm worried about those patients. We may see some significant changes there with the CT. Always they're having that cerebral spinal fluid drainage we're concerned about from the nose or the ear, then we can evaluate for that. If they've got the bloody drainage from the nose or the ear, then I can do that halo test or that ring test to see if we actually get that circle around that. We put that on the gauze or 4x4. But if they actually have the clear drainage, then we can actually check that for glucose and see if it actually has glucose in it. And if it measures greater than 30 milligrams per deciliter on a glucometer, then that's going to be cerebral spinal fluid and not just some type of drainage from the ears or the nose, because it's going to have glucose if it's CSF. Just kind of visualization there to think about with these patients. We're obviously not going to pack those. I've seen people think, well, we could just pack those, but a little drip pad works pretty well just to kind of collect it and keep it from running everywhere else. We have to keep those in mind that if I see the signs, make sure I've got a good ENT exam, I've got a good ear exam. Do I see hemotympanum, or do I see something actually there in the canal that makes me concerned about these patients? Truly, the hemotympanum is going to give us that red, dull appearance. May appear bulging. It doesn't look like what we see with a typical effusion like we're seeing with otitis. They look very different in presentation. And I've seen that before where they think it's a hemotympanum, and actually it's just a arrhythmic eardrum, but it's going to have that presence there. It's not as shiny, and it's very red throughout, not that bright red that we'll sometimes see with an irritation or an inflammation. So we think about major trauma, as I mentioned earlier, it's pretty simple to manage. We do a lot of times talk about the Glasgow Coma Scale. If their GCS is 8, we need to think about intubation and securing the airway. And that's a really good way to go to focus on managing their hypoxia, preventing hypoxia, preventing hypercapnia as well. Several different medications out there we can use. We know etomidate has really good evidence we talk about for RSI, especially for head injuries. We have to concern about the Cushing's suppression, especially for multiple doses, but it does have good benefit for actually decreasing ICP, and it's pretty safe in the head injury patient along with whatever paralytic we choose to use. Our focus on these patients is going to be to oxygenate them and to control that. We want to prevent hypoxia and prevent hypercarbia, but also not cause hypocapnia as well. We usually now only are going to do controlled ventilation in these patients if we're worried about impending herniation. And we're used to get Johnny Windup over there, and we just bag them 30, 40 times a minute, trying to bag their CO2 down to 10. Well, we get some benefit, but then we cause so much more problems because of the vasoconstriction that comes and we get a more hypoxic injury. So if anything, we're going to do a controlled hyperventilation. We're looking for getting like their end tidal down between 30 and 35 if we're able to use capnography. I don't want any lower than 30. I want to maintain perfusion, prevent hypoxia, but not cause hypocapnia as well. That's going to cause even worsening problems, and just focus on their good ability to maintain perfusion, but also their ventilation. So the epidurals, we typically think about these associated with our skull fractures, especially our temporal bone skull fractures. These are usually arterial in source, and so their presentation is usually pretty quick and pretty aggressive onset. Classic one I think about from my days of EMS was two soccer players collided, they impact, one gets knocked unconscious, he wakes up a few minutes later, has his lucid interval, and then goes rapidly out again. But with these epidural patients, they may have that classic, but they also may just have that usual that doesn't have that classic lucid interval. But it's going to involve a very rapid change in mental status. So this is on top of the dura. It's not being controlled. It has really not a good way to tamponade off initially, and you get this large collection of blood there with a rapid change in neurostatus. Usually almost always seen with that temporal bone fracture that we'll see. They may have that dilated ipsilateral pupil, especially when we get more compression on that side. And on CT, we'll see that biconcaved or that lens-type presentation as we see here. So this is on top of the dura. That collection of blood is going to be very formed and go along the surface of the dura and gives us a pretty uniform appearance in these patients. As you can just see with the different cuts down through the slices of this, maintains that visualization pretty well throughout the scan if we're looking at that. And my philosophy is 2 eyes are always better than one, whether it's the physician I'm working with, the radiologist, or whomever, definitely for 2 of us to look at it versus just 1 of us. Where subdural hematomas, we're thinking about venous injuries, so they're below the dura. So with these, we think about patients that have risk for those hemorrhages. Is this my elderly patient? Is this my alcoholic patient? Is this my patient who's on anticoagulants or antiplatelets? Unfortunately, we know that as we get older, if we drink a whole lot, we do tend to have some effect to our thrombocytes, but also we lose some of our water volume of the brain, and that makes the brain a little bit smaller in size and gives it a lot more mobility, so we tend to have more injury of those bridging veins, especially during some type of injury, or especially a contra-coup type injury. But these patients are going to have more subtle change in mental status, a more subtle presentation. And these patients can tend to have a higher mortality rate because they don't have that rapid change that leads to intervention. And so what's the history? Do we have that history of the fall, the head injury? And they may or may not have lost consciousness, but throughout the day, the next day, their headache worsens, they may have some dizziness, but they've had that steady, gradual decline in mental status. And that's the one that really can help us differentiate epidural from subdural is the change in presentation. Epidural, very rapid because it's arterial in nature. That subdural is usually very slow and progressive because it's usually venous in nature. And on CT, we're going to see that more crescent-shaped appearance because it is underneath the dura. It's not being kept in a uniform fashion. It's able to fall on the surface of the brain itself and not be kept in a uniform fashion by the dura itself. But more crescent shape doesn't have as much uniformity to it, but these can definitely still cause significant mass effects, can cause shifting, can definitely affect the ICP, and definitely can increase the mortality. Both of these can be very severe if not addressed aggressively. And then, of course, there are cerebral hematomas as well. All 3 of these are going to result in neurosurgical intervention most likely, or at least evaluation by those subjects outside of our department. But definitely what neurodeficits are they having, and what do we need to focus on there in the ED? We're going to focus on maintaining their perfusion, maintaining their ventilation and oxygenation. And of course, our big concern if we're worried about increased intracranial pressure is the risk for herniation. We know that the brain, the skull, all very fixed box. There's not much room for anything else. Inside that box, we got the brain, we got the cerebral spinal fluid and the blood. There's not room for anything else except for that one opening in the very bottom there at the foramen. And anytime one of those changes, we're going to see significant changes. And of course, our concern is the pressure continues to increase and increase and increase, the risk for herniation. The 2 biggest ones we usually see are going to be our uncal herniation, sometimes referred to as transtentorial, or our central herniation. And what we'll typically see with that uncal herniation is that patient all of a sudden blows a pupil. We're assessing them, we're evaluating, and all of a sudden that pupil just blows. Or they may have bilateral if they have bilateral uncal herniations, but more commonly it's unilateral. But that's the patient that just blows a pupil. That's the patient who just herniated or in the process of herniating down through the transitorium. And that may be a patient who may benefit from some controlled short-term hyperventilation to at least help decrease some of that swelling and some of that perfusion just for a few moments so we can do something else. With that central herniation, that's typically when we see the constricted bilateral pupils. You've got pinpoint pupils bilaterally involving some cranial nerve 3 most likely, and those are the 2 most common things that we'll see. But we could easily see these in other scenarios or other type presentation depending on the type of injury or depending on the process that's going on as well. So we think about concussions, a common thing that we see in the ED as well, and patients, where it's patients or parents or caregivers are asking those questions, do they have a concussion or not? What does CT show? Well, do we always need to image these patients? Probably not. But the true definition of a concussion is when the patient has that transient alteration in mental status. This may or may not involve a loss of consciousness there at the scene, but it is very common. It's very common for them to be very amnesic to the event. And especially the one thing we see a lot of these people is they have those repetitive questioning. Every 5 minutes, what happened? Where I'm at? Who are you? And it's the same thing over and over again. They're constantly asking those questions. If we did a CT scan, it's normal. With a concussion, there is no radiographical evidence of injury. If we actually were doing an MRI, we might see some subtle changes on the MR, but for the most part, the CT is going to be absolutely normal. What we're concerned about with these patients is they may have some post-concussive syndrome. They may have the headache. They may have some dizziness, some nausea for several hours or several days past that. Most people usually resolve within about 48 hours, but we may have some people that may go on for about 3 weeks and have that true post-concussive syndrome, and so we have to be careful with those patients. And my big concern is the risk for that second impact syndrome. Something we have to really focus on with patients and in parents of our adolescents if they have that concussion as our discharge instructions, that we know that patients that have a concussion and if they suffer another head injury before they resolve that symptoms of that concussion, they're going to have some long-term cognitive deficits. It actually may lead to some cerebral edema, some worsening injuries. So we have to really focus on those patients. And anybody with a head injury that has some type of symptomology with it, they need to decrease their risk until these symptoms are resolved. Especially we're talking about sports. With those patients, no contact sport resumption. They can't go back to playing whatever they're playing or anything that's going to decrease their risk of head injury until they've symptomology resolved. They need to have follow-up care to make sure, because if they had that initial injury, they're still having symptomology, and they have another injury before that resolves, they're going to get a second impact syndrome, and that could lead to some long-term cognitive deficits. Look at some of our pro athletes out there, and some of those from boxing and soccer, and all you have to do is listen to them, and you can tell they've got some long-term issues because of that repetitive head injury. We know now that a concussion is, for the most part, mild, but if we add to that, that's definitely going to worsen and increase the complications long-term. So we always get the question is, who needs a CT scan, who doesn't? We talk about minor patients. They come in, everybody thinks they need to see what Dr. House did on TV, and they get a scan and an MRI right there in the ED, or Dr. Google told them they needed an MRI. Well, if Dr. Google can order one in the ED, go for it. But we have some good evidence out there that really helps us look to see which of those minor patients would benefit and have the risk for some of intracranial injury, and who needs a CT and who doesn't. And so the Canadian CT guidelines gave us a pretty good evidence to look for to say who needs CT and who doesn't. And your exclusion criteria is listed here. These patients were not studied. They didn't cover any of the pediatric patients. We'll look at the pre-Karen results for that group of patients. But those that had minor injury, those that had penetrating trauma, those that had focal neurodeficits, they were unstable, they were having seizures, patients that really didn't meet that minor criteria. So what they looked at is who's at high risk for having an intracranial injury in that minor type patient. If they've had a glioblastoma less than 15 at 2 hours after the injury, not initially, but 2 hours after. And we're not considering medications that may have been involved, but if they're 2 hours post-injury and their GCS is not normal, then those patients have a risk that we need to look for those. Do they have a suspected or open or depressed skull fracture? If I'm feeling that little devitt when I'm palpating their skull, then obviously those patients are high risk. Anything concerning for a basal skull fracture. If they vomited 2 or more times, a lot of people, especially kids, vomit when they have a head injury. 1 time's great, but your second time, that increases your risk. And we know with any patient, that does increase my concern, but when they get past number 2, that's the patient who is now considered a high risk and probably would benefit from some type of imaging study. And those that are over the age of 65. As we get older, our brains do lose water mass, they get more mobile, more risk for injury, and of course, especially in our older age population, most every one of them are on some of antiplatelet or anticoagulant for those medical benefits, and we have to make sure we understand that from our history. So for these high-risk patients, it was 100% sensitive for those patients needing surgery. That's pretty good numbers. I like that. That if they fit that category, then we can get a scan and identify those injuries. And then they broke it down into the medium-risk category as well. Those that have amnesia for up to 30 minutes prior to the event, they don't remember anything prior to what happened, that could definitely be a minor patient there. But what was their mechanism? And we've kind of gone away in trauma management from the mechanism and the importance of it, but it does kind of help at least give us an idea of what we need to suspect. Trauma guidelines have kind of changed a little bit, but if they were struck by a vehicle, that's a pretty good significant impact, a transfer of energy. If they were ejected from a moving vehicle, that's a pretty good injury transfer, because whenever they got ejected from that vehicle, they've impacted something else. Falls greater than 3 feet, and of course, fall from 5 or more stairs definitely increase the risk in those patients. So when they combined the high and the medium risk factors, it picked up 98.4% of those clinically important brain injuries. That's pretty good numbers. Now, they didn't include in those numbers the very minor things that do not require any emergent intervention. But 98.4% is pretty good numbers to use that. So some really good evidence to help evaluate who needs a CT and who doesn't. And hopefully we can use those in our practice to either limit the radiation exposure and maybe even shorten the time of stay there and help limit some of the consumption of healthcare dollars. So those patients with anticoagulants and antiplatelets, all we used to have to worry about was really the warfarin. But now we have our 10A inhibitors and our direct thrombin inhibitors with Pradaxa, gabapentin, Xarelto, and all those others out there that have really complicated the scenario and really have complicated the management of these patients. So warfarin's going to affect those vitamin K-dependent clotting factors, where our other direct thrombin inhibitors and our factor 10A inhibitors are going to work on a different part of the pathway. For the warfarin is all we dealt with. We know we can probably give some vitamin K. It may take effect in about 6 hours, but we could use some fresh frozen plasma. We might consider the use of some PCC, and that may help us improve and hopefully stabilize their coagulation to some extent. But with these newer drugs, we don't have a clear-cut way to reverse those yet. I know that the producer and manufacturer of several of those, they're working on their antidotes now. So they made the drug and now they're working on the antidotes. But what can we do? In some of the studies they looked at, that FFP may help, but PCCs are probably the best thing that we have out there. So we have some prothrombin complex concentrates we can give. That's probably going to be the best thing for those patients that are on one of those factor 10A or one of those direct inhibitors, and that may help stabilize their coagulation cascade to some extent. But those are the things we can use out there for those patients, especially if they do have that head injury with that obviously exsanguination risk in here, but also in other areas. For warfarin, we can still measure their PT, their INR. Those are probably not going to be very helpful measurements when we're talking about the patients who are on the other medications. We can look at them, but they're not as helpful as the true patient who's on the warfarin, and I can look at their INR and realize that it is 6 or 8 or 12 help us. So for the most part, most of the guidelines, the evidence shows that patients that are on anticoagulants with a head injury, they get a CAT scan. I really have to have those high-risk suspicion for those patients and need to consider some type of imaging to look at that to see, do they have any injury, do they have any hemorrhage? It could be very small or it could be very major depending on the scenario, but definitely want to make sure that we evaluate for the concerns for that immediate hemorrhage, but also have to focus on discharge instructions or the need for observation for that delayed hemorrhage that some of these patients are at risk for. Do their lab values, we can watch those, get their CT, and we may consider sending some of these patients home, but the focus is, do they have good observation there at home? Do they have that responsible adult, not just an adult, but a responsible person there that can watch them? And not that we're necessarily waking people up every hour like we used to, but they can watch for those changes and be able to get that patient back to medical care if necessary. And so our last section, the CAT scans in our pediatric patients. And we see pediatric head injuries very commonly in some areas, just like we see with our adults. And unfortunately, some of our kids can give us good histories depending on their age, sometimes not so well. So it kind of leaves us in that gray area. What do I have to be concerned about? Mom and dad are over here. They're concerned. They definitely don't want anything wrong with their child, as we wouldn't either. But what are our big concerns? We know that pediatrics do have an increased risk. The skull is thinner. But the nice thing is with some of these kids, especially as they reach up to their older adolescence, with their suture lines not being fixed, they do very well with head injuries. They do pretty well with ICP issues because of the fontanelles in the younger pediatric patients and even up to their adolescence because their suture lines have not formed yet. We talk about hematomas. The ones I'm really worried about are the ones when they're not frontal. Kids get tons of goose eggs up here. We all do. But frontal lobe, that's a pretty thick area of the skull. But if I get back to posterior, occipital, temporal, those are the hematomas that make me concerned because that area is much thinner and that does increase the risk for more significant intracranial injuries and have to increase my risk of suspicion. So there's several things that are out there guideline-wise to help guide who needs a CT, who doesn't, and we'll look at one of those. The biggest thing we know that CT scans have dramatically improved. There's much better. What it used to take 15 minutes to get a head CT, now we're looking at 60 seconds to 90 seconds in most facilities to really get a good scan. So we don't have to worry about the risk of sedation for some of these pediatric patients. But we do know that CT and radiographic itself is not without risk. And one of the studies here show that 1 in 1,000 to 1 in 5,000 children who get a CT have the risk for fatal cancer. Those under the age of 2 have an increased risk of that dramatically. So we need to really weigh those risks and benefits. Is it beneficial to get this imaging study, or can we just do observational study and look at those? So the pre-Karen is the one that we'll look at, that looked at 25 different departments across the ED, gave us a very large number of patients involved in this study to give us some pretty good evidence. Excluded stuff they look for, of course, obviously age of 18, those that have trivial injuries, those with known pre-existing problems, those with penetrating trauma, and those that were repeating for a second visit. If they'd been seen once and they're now back for the same visit, they didn't include those because those patients need to be looked at differently. So for the pediatric patient less than the age of 2, do they have an altered mental status? Then that makes me concerned. Have they had a loss of consciousness for more than 5 seconds? And that's one thing that always gets interesting with history. It's like when people talk about seizures, how long were they out of it? It's hard to tell. Some historians are really good, some are bad, because most people have seizures for 15 minutes. Hopefully they didn't. Very similar to the loss of consciousness. Some people are like, oh, it was only a couple of seconds, or was it 5 minutes? And that's very subjective, and we have to take that as such. How are they acting for the parents? Those are really good key indicators of what's going on with this patient. Do I have that palpable skull fracture? Do I have that non-frontal hematoma? And obviously, was there a significant mechanism of injury? Those are things that are going to make me concerned that those patients under the age of 2, they have earned a CAT scan to make sure that we don't have some type of skull injury or intracranial injury. And one thing I always ask along with that, the parents, especially when they go, oh, they're sleepy, well, when's their usual nap time as well? Because that sometimes plays a role. If it's time for their daily nap, then I'm probably going to be sleepy too. But just keep that as part of your history. Still, our physical exam is definitely going to play a significant role. For those patients over the age of 2, again, the altered mental status they're looking at, do they have the signs concerning for a basal skull fracture, which is very similar looked at for Canadian rules? Was there any loss of consciousness? Was there any history of vomiting? For those kids under the age of 2, they allow us to let them vomit once, like we talked about with adults a while ago. Very common for those young pediatric patients, 2 or under, to have a little bit of vomiting when they have a head injury. But now, once we get over the age of 2, vomiting becomes more concerning, or if they've definitely vomited more than once and definitely had that projectile type stuff. And of course, mechanism still plays a role as well. So I looked at these 2 groups. For the group under the age of 2, it was 100% negative predictability for clinically important brain injuries. That's pretty good. That if I can look at these pediatric patients and give mom, dad, whoever, some pretty good reassurance that based on the evidence, your child doesn't need a CT scan, they don't have a significant head injury, those are some good things that can help us justify how we manage those patients. And then for those 2 or older, negative predictability was 99.5%. Still very good evidence to reassure us as providers, but also to use to reassure the parents or even the patient that we do not need a CT scan, that we can base upon assessment and observation. And when they really focus on it with these patients, that do we need to do a CT? Maybe not. Can we observe them? And not that we want to keep patients for 4 to 6 hours in the ED along with all of our other patients, but there is good evidence that observation 4 to 6 hours is a good way to avoid radiographic exposure, but also do a good observation and make sure we have evidence-based practice that these patients don't need further intervention and they're safe to be discharged home. Obviously, clinical judgment, clinical assessment always should take superiority over everything else. What is your gut feeling? Sometimes is going to help us as well. But based on the evidence, we know that we do have some great guidelines that can say who needs imaging, who doesn't. Observation is always a good alternative with these patients who have minor injuries, whether we're talking about they're in the hospital or even at home, as long as we have good education of the caregivers, whoever's with them, to observe them and make sure there's no decline in status. Observation can work very easily. Thank y'all very much.